So, students, today we are going to start a new chapter, rectum. Okay, so it's very important to know the anatomy of rectum in detail so that you can understand the pathology and diseases of rectum. So, how long is rectum? Rectum is about 15 to 18 centimeter long. It begins where the sigmoid colon ends, okay, and ends at the anorectal junction, which is 4 centimeter from the anal verge. So how do you know that sigmoid has ended here and rectum has begun? You see, sigmoid colon has got, and all the colon has got tinea coli. 3 tinea are there, and appendices epiploe is there. Okay? These 3 tinea merge together and form the outer muscular coat of the rectum. So you will not find tinea coli over rectum. So where the tinea disappears, appendices epiploe disappear, you know that rectum has begun. Okay, this is about at the level of sacral promontory and ends about 2 centimeter above dentate line where anal canal begins. Okay, we divide rectum into 3 parts: upper, middle, and lower, because that has got bearing on the rectal carcinoma also. So the upper rectum, which is about 5 to 6 centimeter, is covered by peritoneum, peritoneal reflection, anteriorly and laterally. Okay. Whereas mid rectum is covered by peritoneum only anteriorly, and the lower part of the rectum, lower third of the rectum, is completely extraperitoneal. It's devoid of peritoneum. It's completely extraperitoneal. So upper third covered by peritoneum anteriorly, laterally, middle anteriorly only, lower part completely extraperitoneal. Okay. So this is about the peritoneal reflection of rectum. Now you see from inside you can see there are valves of Houston. Okay, there are 2 on the left side, superior and inferior. It's valve like infolding of the mucosa is there. We call it valves of Houston. So 2 on the left, 1 on the right. Superior and inferior on the left, 1 on the right, middle on the right. Okay. So rectum, what is the blood supply of the rectum? Arterial supply you have to know. You know, inferior mesenteric artery is there, which gives left colic, sigmoidal arteries, and then continues down as superior rectal artery, which is single artery behind the rectum in the mesocolon. It supplies the rectum. The lower part and the lower middle part is supplied by, also supplied by middle rectal artery, which comes from internal pudendal artery, internal iliac artery, and inferior rectal artery, which comes from internal pudendal, which comes from internal iliac artery. Okay, so basically rectum is supplied by superior rectal artery, which is continuation of inferior mesenteric artery, and reinforced in the lower part by middle rectal artery, inferior rectal artery, which comes from internal iliac artery. Okay, venous drainage of rectum is similar. Venous drainage, mostly the venous drainage goes up by the superior rectal vein. Okay, superior rectal vein to the inferior mesenteric vein, and inferior mesenteric vein, you see, superior rectal vein, inferior mesenteric vein, which joins the splenic vein, and splenic vein joins the superior mesenteric vein behind the neck of pancreas to form portal vein. So it drains into portal system, isn't it? A lower part, middle rectal vein, inferior rectal vein, they go into internal iliac vein, which goes into common iliac and then into inferior vena cava. So there is a site of portosystemic communication here also, isn't it? The lower part of the rectum, majority going into the portal system via superior rectal vein, inferior mesenteric vein into the portal system, and some goes via middle rectal vein, inferior rectal vein into the inferior vena cava. Okay. So now the lymphatic drainage of rectum. Lymphatic drainage, as you know, will follow the vessels. So majority of the lymphatic will go along the superior rectal vessel and go in the inferior mesenteric lymph node, and from there to para-aortic nodes. Okay, inferior mesenteric nodes, and from there to para-aortic nodes. whereas some lymphatic will go along the middle rectal vessel and inferior rectal vessel, and they will go into the internal iliac lymph nodes. Okay, so some from the lower part also go to internal iliac lymph nodes. So majority of the lymphatics will follow the inferior mesenteric artery and go into inferior mesenteric nodes, and some will also follow middle rectal and inferior rectal vessels and go in internal iliac nodes. Okay, what about nerve supply? Rectum, as you know, has got sympathetic and parasympathetic supply, autonomic nervous system, isn't it? Sympathetic system comes from L1 to 3, 4. L1 to 3, 4. Okay, whereas parasympathetic comes from S2, 3, 4. These sympathetic nerve form a plexus over the lower part of the aorta and below the bifurcation. We call it hypogastric plexus. From there, two nerves descend down, hypogastric nerves. Okay, and then they join at the lateral wall of the pelvis. This is where the parasympathetic nerves comes from S2, 3, 4, sacral phenomena, and they form a plexus at the lateral wall of the pelvis. Okay, so this sympathetic fibers from hypogastric nerves and parasympathetic form a plexus there, which is called pelvic plexus. And from there, postganglionic fibers emerge containing both sympathetic and parasympathetic, which traverses laterally and then comes anteriorly and supplies the rectum and also prostates and vesicle and genitalia. So this is the nerve supply, which is important when you are doing the rectal surgery. You can injure these nerves and that lead to many complications. Okay, so this is important to know. Something about fascial covering of the rectum. It's also important. See, rectum is a tubular structure, isn't it? It has got two coverings of, as you know, from inside out there is mucosa, submucosa, muscular layer, isn't it? Serosa. Then there is a visceral layer of pelvic fascia. And then outside there is a parietal layer of pelvic fascia, which is called fascia propria of the rectum. Fascia propria of the rectum. So in between these two, visceral and fascia propria, there is fat, lymphatics and vessels. This is also called mesorectum of mesorectum. Okay, this is a small amount of fat is there, most prominent posteriorly and laterally, and less anteriorly. So, and enclosing fat, lymphatics and vessels. This is very important because when we do total mesorectal excision, TME, we excise this whole tube in between these two fascia, visceral fascia and fascia propria, to take out all the lymphatics and reduce the chance of recurrence. Okay, and as I said, there is a fascial covering. The peritoneum covers up till the upper and middle part of the rectum. Okay, so you see, focus on this diagram. You see, this is rectum, and this is anteriorly in male. What is there? Bladder, prostate, seminal vesicle, isn't it? In male, this is there. This peritoneum, which reflects from the middle part, and then there is a bib of fascia there. This is nothing but double fold of peritoneum. This is which separates rectum from the bladder and prostate. This is called fascia of Denon barriers. This is fascia of Denon barriers, anterior to the lower rectum. Okay, anterior to the lower rectum, there is a fascia here, which is called Denon barriers fascia, separating anteriorly bladder and the prostate. This is a tough fascia, and it also protects from rectal cancer from invading prostate and bladder easily. In females, what happens? There is uterus and posterior vaginal wall, okay, and the pouch of Douglas is there. So that fascia is present in females also, but we mostly call it rectovaginal septum. Rectovaginal septum. Okay. Behind the rectum, you see the sacrum is there, and this sacrum there is a sacral venous plexus. Veins are here, and it is covered by a fascia again, which is called retrosacral fascia or Waldeyer's fascia. It's also a tough fascia which line behind the rectum. This protects the, we don't have to injure or open Waldear's fascia, otherwise there will be torrential bleeding from the sacral plexus of vein behind. Okay, so behind there is Waldear's fascia, anteriorly peritoneal reflection, and then there is Denon-various fascia. In female we call it rectovaginal septum. This is important fascial relations in rectal surgery. And so this is about anatomy of rectum. Okay, examination of rectum. As in anal canal, I told you have to do a DRE, put the patient in left lateral or Sims position, and do a digital rectal examination. Your finger, average finger, can reach up to 8 centimeter from anal verge, and you feel for any intraluminal mass or mass in the rectal wall. Okay, and then remove your finger and see if there is blood in anything. You can use proctoscope. Introduce a proctoscope and examine the lower part of the anal canal and lower part of the rectum. Above you can examine by sigmoidoscopy. Sigmoidoscopy, you see, is of two types: rigid sigmoidoscopy, and which is about 25 centimeter long. This has got channel for air insufflation and light source present. You can visualize the mucosa. There is a flexible sigmoidoscope also available. Okay, and if you want to examine the whole colon, of course, there is a colonoscope, which is a flexible instrument which has got air insufflating apparatus and light source, and image can be produced on the TV, and you can visualize the whole colon. Okay, thank you.